Hello, everyone. I'm excited to be here today to talk to you guys. It's been a long time since we've seen you guys, and we want you to know that we're still out here. We're still working along with you guys, and we're really excited to bring our retreat to you guys virtually this year. One of the things that I'm going to talk about with you guys here today is including lay personnel or non-medical personnel in mocks. What we're proposing today as a program is to involve your non-medical personnel as a participant in your mock processes. Normally, we just have sites that call in and do their mocks with just nursing, but your hospital and your departments are full of untapped potential to be able to include them in your mocks. And we'll talk a little bit about what this looks like and how it can help improve your patient outcomes and improve your processes in your department. So the proposal is that activating this relationship will help foster and strengthen a sense of community within your department and working towards one common goal, which is to improve patient safety and improve safety measures within your department. And everyone within your department, within your hospital, can help with this process. Knowledge and awareness of stroke signs and symptoms will become more widespread throughout your facility if everyone knows what the goal is of the department, what the goal is of the hospital, if everyone has the same goals moving forward concerning patient care and patient outcomes. It's more likely that it will become more pervasive within your department, resulting in an increased successful implementation within your department if everyone's involved in that process. So what is a community? Communities can look like many different things depending on where you're at. It can either be at work, at home, a small knit community within your home, within your neighborhood. We're all one community as a state. You can break that down by district. You can break that down by just a county, just one state, or you can even look as locally as your local emergency department. So your emergency department is going to be your number one community that we're kind of talking about today, but think about it in the regards as the same thing that you do for your state. So some definitions, how we look at communities, how we define communities, are a group of people living in the same place or having a particular characteristic in common, especially if they practice common ownership and owning that goal and having the same values within that community, and then practicing that ownership together will help the community achieve their goal. So what makes a community successful, especially looking at in your emergency departments, within your hospitals? Diversity is our number one advantage that we have. There are many different professions and many different job titles that go into making a cohesive and collaborative effort within a hospital. Being inspired, having some inspired members and initiatives within your hospital, having successful leadership, people that strive to really implement certain types of goals and achievements within the department, communicating those goals, and then looking for active employee engagement also within your department and making that one of your goals. So what does this mean and why is it important? The more diversity you have in stakeholders, the more capacity you hold for change. And that just really talks about how there are many different people that make up parts of your community, whether it is going to be you can see different pictures here, people that bring in food service workers, receptionists, clerks, patient advocates, housekeepers, patient transport, even police officers and security personnel. These are all untapped areas in the hospital that you have to really make a difference and help educate these people so that they can help the patients in the hospital to determine if they're having a sudden change in condition, to alert medical personnel so that they can have faster response times to patients who have changing in their conditions. So this is kind of just what we talked about, the untapped potential. And this not only can concern the emergency department, but it also can really be transferred into inpatient units as well. Many of these personnel may have many interactions with patients on a daily basis. If there is a noted sudden change in the patient's condition, all personnel should be empowered or feel empowered to come to a medical personnel and state their concerns and let them know that they feel like there's something off with that patient or that they may need to go in and do another evaluation of the patient. So any personnel should really have that confidence about approaching a medical personnel. And the way that we do that is to help them be more confident about their observations, what they're seeing, and then what they should do about that after they start to have some kind of a concern about a patient. So teamwork. What our goal here is to invite a non-medical personnel to participate in a mock. You all know that you're required to do a monthly mock every month, but also giving other people within your department, within your hospital, an opportunity to take part in this. This will help them to understand what the goal is within your department, help them to understand the process, and help them to both actively learn and become a partner in that with you. So I have a scenario here that we'll talk about, and imagine that a registration clerk comes into a patient's room to bring them their admission paperwork. The patient suddenly has a droop on one side of their face and trouble signing their paperwork due to arm weakness. We have 3 different options that can happen here. Just imagine that the clerk doesn't recognize that the symptoms are concerning for a stroke at that time, and the clerk just walks away, doesn't do anything, doesn't alert any personnel, and the patient stays in the room and they're not seen again by medical staff for 30 minutes. And as we all know, strokes are very extremely time sensitive and seconds count with strokes. So imagine a patient sitting in that room for 30 more minutes and the devastation that that stroke is having on that patient now that they're not being attended to or haven't been notified of a change in the patient's condition. Option number 2, the clerk assumes that the nurse knows of the patient's current condition or that they'll eventually notice when they enter back into the room. The clerk's hesitant to become involved in patient care. The one time she or he said something, they were reprimanded for stepping outside of their scope of practice or becoming involved in patient care when it wasn't. That's not a part of their job description. They're not even really sure that if what they've noticed is concerning with the patient. So the clerk leaves the patient's room and returns to her desk without alerting medical staff. The patient's not seen again by medical staff for another 45 minutes. Option 3, this is the option that we look for to be the outcome of implementing this proposal that we're bringing to you guys today. If you can imagine, due to a mock experience, the clerk immediately recognizes that the patient's exhibiting signs and symptoms of a stroke. She knows that time is critical and immediately alerts the nurse that she's concerned that the patient in room 2 may be having a stroke. The nurse immediately reports to that patient's room to evaluate the patient. A code stroke is activated and the patient is in the CT scanner within 5 minutes. So what does the option 3 afford to your patient? This allows for multiple sets of extra eyes to be on the patient at all times, to be able to act as an opportunity to alert medical personnel of a sudden change in a patient condition. This, in summary, really just comes down to offering our patient quicker response times. Faster door-to-needle times is going to equal a better patient outcome. As soon as we can get that medicine into that patient, if they're a candidate for TPA or they may be a candidate for a thrombectomy, the sooner that we notice that and that we really hone in on that patient and getting that care facilitated as soon as possible, getting that medication in as soon as possible, the better quality of life that your patient's going to have moving forward. And also, just to reiterate, going over the Be Fast acronym with all of your staff, all of the people that work within the hospital. Doesn't matter what department they work in, if they're medical or non-medical, everyone should know the signs and symptoms of a stroke. Is the patient suddenly having any difficulty with walking, having a difficulty seeing with their vision? That can be either in one eye or both eyes. A sudden facial droop to one side of the face, the patient having a sudden weakness in one arm or leg, and patient having sudden slurred speech or trouble speaking. And then, of course, T is for time to alert and call 911 to get help for these patients. And this rings true whether you're out on the street in your day-to-day life, teaching people about this at work, teaching people about this at home within your community, but making sure that your work community is very educated and knowledgeable as well, so that if they do notice that this is happening to one of their coworkers even or a patient, that they know to alert someone as soon as possible to get help in a timely fashion. Thank you.